Good afternoon, everyone. I'm Mark McClellan. I'm the director of the Duke-Margolis Institute for Health Policy, and I am really pleased to welcome everyone here with us in person and online for this afternoon's event on advancing whole person care for all through North Carolina's State Transformation Collaborative. For those of you who are here in the room, as well as those of you who are joining us online, I hope the heat's not getting to you. We're really pleased to see you for such a important and timely event. We have people joining us from around the state, around the country. We have government leaders taking time out of their busy schedules from the state government here in North Carolina and from the Centers for Medicare and Medicaid Services. You'll hear from all of these perspectives during the course of today's meeting. We go to the next slide. I can't start a meeting these days without QR codes. And I'd like you all to know that you can scan these QR codes to view relevant materials for today's meeting. One of these focuses on the alignment proposal put together by participants in the State Transformation Collaborative, who's joining us, coming from a range of perspectives. While you're typing in those answers, we're seeing a lot of people involved in different parts of healthcare, oral health, a really important part of disease prevention and health maintenance, people involved in care delivery from health systems, people involved in research and academic work, ACO population health, part of the value-based care reforms that we're undertaking. So really appreciate seeing the range of perspectives with us today. Glad you're getting some Slido practice while we're seeing all of these different perspectives come up. We are going to have a significant part of time for comment and public input during the course of the meeting. So glad you're with us and glad you're engaging. I want to now move on while we'll continue to track this. If you haven't entered yet, please go ahead. Alignment is a very important work of our state transformation collaborative efforts. This is a technical definition of alignment. Practically what it means is, look, we are trying to draw on the best evidence and a wide range of experiences to identify ways to move forward together more effectively. Alignment is not necessarily exactly consensus, that we talk about a consensus statement later. It doesn't mean we agree on everything. It means that we are trying to implement a process whereby different perspectives, perspectives that may not have an easy opportunity to work together closely on important policy issues and important health reform issues can come together here. We focused on identifying ways to bring down the cost, the administrative burden of healthcare generally, but particularly healthcare as we reform it in the direction of lower costs, more access, and more of an emphasis on prevention and what matters to people. So a focus on identifying measures, administrative steps, data sharing, things like that can have impactful and practical progress, can facilitate practical progress on these important reform issues. When people are working together, next slide, we want to make sure that we're not violating any antitrust issues. The details are on this slide. The main point is we do not discuss any commercial confidential information. This is not a place to make agreements or contracts. It's a place to work together to identify the best path forward for supporting shared goals in reforming health and healthcare. Less administrative burden, better results and outcomes for people. This is happening in the context of a changing policy landscape. The next slide, I'm not going to go through all the details on this slide, but as you know, there are some new federal priorities in place with the change in administration, priorities that include making America healthy again, with an emphasis on preventive care and addressing the non-medical factors, diet, lifestyle, that can contribute to risk factors in chronic disease progression and burden. Our federal partners in many of these state-based reform efforts at CMS have implemented some new priorities as well. The Center for Medicare and Medicaid Innovation, which is well represented with us here today, recently announced a strategic refresh focusing on evidence-based prevention, empowering patients to achieve their health goals, and improving choice and competition in our healthcare system. Has all been reinforced by a CMS-wide, really HHS and government-wide priority on advancing data availability, electronic health data availability under people's control, available to their clinicians, their healthcare providers to help them get better care, and then leveraging new technology possibilities, digital health, AI, to help improve access to care, engagement, and steps to reduce health burdens and improve outcomes, and also to reduce the administrative burdens of healthcare as well. This was reflected in a recent request for information by CMS in collaboration with other federal health data agencies on advancing access to innovative health technologies for individuals and families, that goal of more accessible care at a lower cost and with less burden. A new focus of the public-private healthcare payment learning and action network, which has supported efforts here in North Carolina, goes along with these priorities as well. We'll talk about those issues in our upcoming sessions too. And then there are Medicaid reforms affecting states. As you all know, Congress is considering a reconciliation bill that intends to bring down future tax burdens and facilitate economic growth, but also, as written, may have significant implications for states in terms of Medicaid coverage and eligibility and work requirement determinations, as well as payments to healthcare facilities, hospitals from states. And right now, here in North Carolina, as many of you know, a evidence-based program, Healthy Opportunities Pilots, that aligns with a lot of these priorities is currently not included in the state budget under discussion. We're going to talk about this changing policy landscape. It emphasizes why collaborations like the State Transformation Collaborative here are so important, because there is common ground we can agree on to reduce burdens and improve outcomes in this changing environment. And we hope that our State Transformation Collaborative will also help our state and other states and our federal partners in this work identify effective ways to reduce burdens and to test out and pilot and then improve ideas for doing so. We have a strong base of collaboration here in North Carolina to do all of that. So with these landscape issues in mind, I'd like to turn to the meeting objectives. We want to today highlight how multi-stakeholder alignment can help to advance key shared goals that have proven challenging to fulfill, getting to more value-based care, getting to care that is administratively simpler, and then using these reforms to address gaps in health, reduce differences in health across different population groups, rural individuals and subpopulations, others who have been underserved in our healthcare system. We also want to highlight how the North Carolina State Transformation Collaborative is having an impact through its approaches to advance alignment around performance measures, data infrastructure, identifying gaps for improving health and practical steps to address them, how those steps are actually having an impact. Here are some examples and experiences from people who have participated in these efforts and been impacted by the programs affected. And of course, we want to look ahead. So we've made some progress to this point. We obviously have a ways to go in a challenging environment. How can we build on the foundation that we've established here in the State Transformation Collaborative's early days? On the next slide, I just want to give a special thanks to the wide range of people and organizations that have participated in our getting to this point and have actually signed on to the North Carolina State Transformation Collaborative Alignment Proposal so far. You're going to hear from a number of these active participants today. And I do want to make sure that we are extending an invitation here to everyone. If you or your organization is interested in participating in the North Carolina State Transformation Collaborative and potentially signing on to our alignment proposal, we do want to hear from you. We are continuing to accept sign-ons and broaden the reach of our effort. The alignment proposal itself, and you saw the QR code before, is on the Duke-Margolis website. So more details there on understanding our work to date, our goals, and what may happen next. Thank you all for letting me set the context for today's meeting. We have a lot of ground to cover, and I'd like to start doing that right now by welcoming Dr. Larry Greenblatt, who's State Health Director and Chief Medical Officer at the North Carolina Department of Health and Human Services. Larry is a longtime colleague at Duke, spent 3 decades here with a deep focus on community health, behavioral health, integration into primary care and care delivery, and innovative health professions education. Larry's going to provide an update on some of the North Carolina HHS goals for care transformation, how the multi-stakeholder collaborative efforts begin for advancing health and well-being in North Carolina. And then we're going to hear after Larry from Dr. Rebecca Whitaker, Research Director here at Duke-Margolis, who will provide an overview of the North Carolina State Transformation Collaborative work to date. We are going to have comments and discussion after this, so please make a note of any questions or comments that you have, and we'll get to that too. Larry, thanks for being here.
Don't take my notes. Okay. Good afternoon, everybody. Hope you're surviving the heat. I got to spend quite a bit of time outside today in my suit. I don't recommend that. So I was a Duke physician until May 31st, and June 2nd, I started as State Health Director and Chief Medical Officer at DHHS. And if you're concerned, I did take off Sunday, June 1st. That was my retirement. But I'm really delighted to be here. I'm honored to be with you at this meeting. I was participating in the State Transformation Collaborative through my Duke role, which was involved a lot of Medicaid leadership, and I was medical director for our network, and I served on a number of statewide Medicaid committees and panels and did a lot of policy work there. And I've been involved with the Medicaid space really since 2008, when it was back in the CCNC days. Some of you may remember that. And we were Northern Piedmont Community Care. At North Carolina Department of Health and Human Services, our mission is to improve access to whole person healthcare across the state, with the goal to create a healthier North Carolina for the more than 11 million people who live and work here. One of the core principles of my work in medicine has been to improve whole person health by making available mental health and addiction services, particularly in primary care settings, because for many, there is no health without addressing these concerns. In addition, I worked at a safety net clinic for my 31 years at Duke, and am keenly aware of the role that the health-related social needs play in increasing individuals' risks for health conditions and poor health outcomes, as well as making it difficult for them to take care of themselves and to just simply attend their visits and the like. And this is a big challenge that I know that the State Transformation Collaborative wants to work on. Of course, people who don't have adequate food or nutrition, housing or transportation end up in the emergency department more often and are more likely to need hospitalization as well. So just we need to treat the whole person. I'm thrilled to have started this position as State Health Director and Chief Medical Officer at the Department of Health and Human Services. It is indeed a challenging time. People ask me, what's it like? Well, it's a bit of a crisis mentality there because of the things that are changing in the funding of Medicaid and the SNAP program and other things. We're seeing a lot of cuts, but the folks that I work with are deeply determined to respond, to do what they can to really serve the people that are our responsibility, the people that we care about in the state. So it's really kind of a really wonderful thing to be in rooms full of people who are really capable and really deeply committed to this whole person care model. As a lead partner in this work that focuses on whole person care, DHHS is excited to have signed the alignment proposal along with the 30 plus other organizations we were on there in the state to improve population health, enhance the patient experience, reduce healthcare costs, and decrease administrative demands on healthcare providers. And as a person who did primary care for 31 years, I say thank you on the burden reduction. It's long overdue. This proposal is the culmination of over 2 years of multi-stakeholder collaboration and hard work across health plans, healthcare provider groups, clinically integrated networks, health systems, employers, CBOs, and state entities, including my own and the HIEA. Together, our priority to advance health by increasing opportunity and outcomes for people who face greater health and situational challenges across the state can be bolstered by the STC's effort to focus on 2 things we see at DHHS as fundamental. First is improving data sharing between plans and providers and broader health and social care teams with a particular focus on quality measures to ensure that both providers and plans can leverage these data to inform decisions at the point of care and resolve care gaps. Second, we have a great resource and partner in the state with the NCDHHS. And so the STC's efforts to build and uplift their technical work with NC Medicaid and others to share data and improve care quality can really help expand our efforts. The STC's efforts to reduce provider burden through performance measure alignment and streamlining data sharing support our goals to not only ensure that providers have the time and insights to meet the complex needs of their patients, but also to continue to strengthen our workforce by reducing provider, and I'm going to add, and team burden and burnout over the many administrative tasks that take time away from patient care. In the office where I worked, our nurses, our front desk staff, our medical records people, it was a team effort to meet these forms and completions and online things that we needed to fill out just to make sure our patients could get the care that they needed. It's not just providers. The STC's efforts to reduce provider administrative burden can also support a broader pathway towards value-based payment that the Division of Health Benefits or the Medicaid program has been spearheading. If we can reduce administrative burden and make critical data more readily available for providers, especially those providers caring for patients in rural and underserved areas, we can support greater participation in value-based payment schemes throughout the state and focus our resources on investing in health rather than in healthcare services. Of course, this work can't be done alone. The Transformation Collaborative is a valuable resource for bringing people together so we can all collectively focus on improving health and well-being in our state. In partnering with the Duke-Margolis Center to lead the State Transformation Collaborative, DHHS adds momentum to the STC's effort to leverage cross-sector stakeholder engagement and to contribute to the common mission to advance high-quality, whole-person care for all 11 million North Carolinians. Right now, the healthcare environment in our state and nation is in flux, including funding for Medicaid, SNAP benefits, the continuation of innovative programs like our Healthy Opportunities pilots. By the way, Dr. McClellan, a little bit of optimism in the mini budget. There was a small amount of money towards that. It wasn't a lot, but something. And other models that advance our work to address health disparities and make a healthier and safer North Carolina for all. While we may be experiencing a shifting landscape, these headwinds remind us that collaboration is critical and we need partnerships like those fostered by the State Transformation Collaborative. During these uncertain times, the state can play a role by continuing to do the important work of bringing multi-stakeholder groups together, not only to establish our goals, but to remain focused on these priorities and to further our collective efforts to find the bright spots and build on these successes and ultimately strengthen the healthcare system across our state. DHHS has been proud to support and co-lead this effort, but we are most excited to collaborate with STC partners to implement the commitments that we have made in improving health and well-being for North Carolinians through coordinated and aligned approaches. Thank you, and I know we'll all learn a lot from today's program, and I'm looking forward to hearing from our speaker. And now, Dr. Rebecca Williams.
All right, well, good afternoon, everyone, and thanks for being here. And many thanks to Dr. Greenblatt for those opening remarks and really giving us the charge for why entities and initiatives like the State Transformation Collaborative are so critical in kind of an evolving policy landscape and charting a path forward where we can all work together on shared challenges and that pathway to practical solutions. So over the next 10 minutes or so, my charge is to highlight how the North Carolina State Transformation Collaborative has made progress over the past year, preview a little bit of our alignment proposal and illustrating how the State Transformation Collaborative is now transitioning from kind of this planning phase, all the work that we've done together over the past 2 years, into an implementation phase. So I'll plug again some of our publications that we had earlier in the slides with the QR codes to learn more about the initiative through the alignment proposal itself, which you can access online, detailing the decision points that our stakeholders have made to date, as well as a companion piece published by the Milbank Memorial Fund just yesterday that highlights really how we got to this place. So how we were able to work together over the past 2 years and reach those decisions that are conveyed in the alignment proposal. So to back up just a little bit, the State Transformation Collaborative was originally launched as part of a broader public-private partnership of the Healthcare Payment Learning and Action Network and the Centers for Medicare and Medicaid Services, designed to promote value-based and whole person care to advance health for all through multi-stakeholder partnerships. North Carolina was one of 4 states participating in this initiative, along with Colorado, Arkansas, and California. And definitely want to acknowledge that our work in North Carolina has been supported by the Department of Health and Human Services, and we at Duke-Margolis have been serving as the neutral convener. And I want to underscore that North Carolina was selected to participate in this national STC initiative because North Carolina is really a leading model for how to shift from paying for healthcare services to investing in health. The state has implemented Medicaid managed care and Medicaid transformation with an emphasis on value-based and whole person care, launched Medicaid expansion to extend health insurance coverage and access to services to now more than 660,000 individuals in our state, as well as implemented the landmark Healthy Opportunities pilots, and we are holding on to our optimism there, Dr. Greenblatt. We also see similar investments in value-based care and whole person care in the commercial sector in our state. And these approaches really appeal to payers, providers, and other stakeholders alike because of the flexibility to design care models to really meet the needs of patients and families. But North Carolina healthcare leaders need help streamlining how all these different health reform programs are being implemented, really to support the healthcare and social service system's capacity to provide whole person care. Reduce time spent by providers on administrative tasks, as Dr. Greenblatt was outlining, so they can really focus on caring for patients. And finally, measuring the state's progress toward meeting its health reform goals. Multi-stakeholder alignment on the components of payment models on things like performance measures and data sharing can make it easier for provider organizations to adopt value-based care arrangements. But getting into agreement on some of those practical steps to achieve alignment is a significant undertaking when stakeholders have varying approaches to how their organizations work toward their own strategic goals. And so this is really where the State Transformation Collaborative comes in. Again, launched in February of 2023 to identify strategies to support and coordinate across both state and national health reform efforts to ensure we are achieving our intended goals. Many of these transformational efforts exist in silos and could accomplish a lot more when brought together through public-private collaboration. And so this initiative aims to kind of bridge those different silos, encourage collaboration across stakeholders who may not normally interact. So the STC, the North Carolina State Transformation Collaborative, convenes stakeholders to coalesce around shared goals to improve health and well-being in our state and to identify some of those key challenges and practical solutions to help the healthcare system achieve those goals. Some of the different stakeholders involved in this initiative, as you kind of saw previewed on that slide with all the different organizations, but include health system representatives, healthcare providers, health plans, clinically integrated networks, subject matter experts, community-based organizations, and state government entities like North Carolina Medicaid and the Health Information Exchange Authority. We've organized this effort through a series of strategic leadership and technical working groups, and really feel like this initiative can serve as a vehicle to facilitate alignment and collaboration on key payment and delivery system reforms, including national reforms and how those are implemented in our state. This is a process also that other states can and can apply to advance healthcare transformation and improve health outcomes in their own states as well. So we're excited to share with you all how we're moving this first focused area of work into action during today's third annual public meeting of the State Transformation Collaborative. So to do this work, I just want to highlight that the stakeholders involved in the State Transformation Collaborative work together to identify shared goals that are shown in that blue bar there. So improving population health, reducing costs, relieving provider burden, enhancing the patient experience, and addressing health disparities. And from there, work together to identify some key strategies where folks thought there was an opportunity to accelerate progress, address shared challenges, in the move toward value-based and whole person care. And those are highlighted in the green bar, aligning performance measures, improving data sharing infrastructure, and enhancing health disparities data. And applying this through cross-stakeholder engagement and thinking about how to advance coordinated care models with a focus on primary care. So from here, we work to get more granular over time to move from those shared goals into action. So this sort of looks like an org chart, and it's a kind of the process map for how we develop the alignment proposal, moving from those shared goals into the strategies, and then from the strategies, thinking about what are those specific action areas that we can focus on to advance work on those shared goals, and then what are the specific alignment opportunities that build out from those action areas. And now we're kind of focused on the purple box phase, which is the implementation and evaluation plan, thinking about how do we actually translate these into action and how do we assess our progress. I will say at each phase of the work, what's really important is that we are building from common challenges that folks have identified, and again, thinking about those practical solutions to address those shared challenges. And our intent has not been to get full consensus on the best path forward, but really to engage in a constructive process that can advance our shared health reform goals. So in terms of where we are now and the progress to date, we have identified and continue to refine those action areas within each of the three strategies, releasing our first iteration of the alignment proposal last May, which kind of showcased the progress that we had achieved to date on those. And then over the course of the past year, have continued to gather stakeholder feedback on the alignment opportunities and flesh those out more, and then focused on the multi-stakeholder commitments for collective action. And so that's what we're really excited to showcase here today. And from today, we will continue to move into that implementation and evaluation phase to measure and track progress. I do want to call attention on the bottom of this slide. You'll note the number of convenings that we've held over the past few years, as well as the stakeholder learning calls, just to underscore the amount of work and dedication that it takes to get to this point from all of our different stakeholders. So we're really grateful for everyone's participation there. We have translated the agreement we've built through convenings into the alignment proposal for a few key reasons. One, we want to be able to document the progress that we're making toward the State Transformation Collaborative goals. We also want to motivate action on a set of short and long-term alignment opportunities designed to align performance measures, improve data sharing, and enhance health disparities data. And then finally, illustrate how we can build on this initiative going forward for additional efforts to collaborate on shared challenges. So very briefly, I'll summarize some of the alignment proposal itself and the multi-stakeholder actions to achieve shared goals. So first, focusing on reducing administrative burden associated with performance measurement by focusing on aligned implementation of common performance measures. Two highlighted here are glycemic status assessment for patients with diabetes and controlling high blood pressure, because we know these are clinically meaningful measures. They're traditionally hard to collect and report on, and they're associated with persistent disparities. So from there, we said, okay, what are the data sharing opportunities that we can focus on and to streamline the performance measure reporting of those two initial use case measures for aligned implementation? And finally, enhancing the quality and availability of health-related social needs data in the state and working to align on the collection, sharing, and use of these data across stakeholders to reduce health disparities. Very quickly, I just want to kind of illustrate how this is the progression of one of our strategies, the data sharing strategies, into specific alignment opportunities, starting again with the shared problem of variation in measure specifications, collection, reporting, presenting barriers to interoperability and burden on provider organizations to report performance measures. So focusing again on those two use case starter measures. For aligned implementation to explore the data strategies responsive to where organizations are, while also tracking toward national interoperability standards and identifying kind of what is the infrastructure and support we can bring to bear in North Carolina. And so the STC stakeholders have agreed to pursue the following action areas: streamlining supplemental data submissions for performance measurement, identifying ways to move toward national interoperability standards, and building a robust ecosystem to support data sharing in North Carolina. So again, I won't spend much time here, but just wanted to underscore the specific alignment steps that we are proposing within each of these action areas, again, meant to be responsive to where organizations are. Those that are, we talk a lot about kind of those that are ready to drive on the highway for data sharing and go 70 miles an hour, and organizations who maybe need to stay on a frontage road for a little bit, but that want to track on to the highway as well. And so how can we develop alignment opportunities to respond to the varying resources and capabilities that organizations can bring to bear in these spaces. So streamlining supplemental data submissions, something we've heard a lot about, is really burdensome for provider organizations, creating different essentially Excel spreadsheets to send to payers for clinical data extracted from their EHR that may differ in non-meaningful ways. So what can we do there to kind of streamline that process and make it easier? All the way up to kind of building a robust data sharing ecosystem, identifying supporting steps needed to leverage the North Carolina Health Information Exchange Authority as a trusted source of data for performance measurement. So I really want to spend another minute thanking the organizations who have participated in the 20 plus convenings and 100 plus calls that we've done over the past few years, and those who have signed on to the alignment proposal. It's really a reflection of the importance of this initiative, that these organizations keep coming to the table and are willing to kind of tackle some of these sticky challenges and identify paths forward for high quality and whole person care for all. We appreciate everyone's dedication and engagement throughout this process and are very excited to work together in the implementation stages in the coming months. So shifting now to our first panel for today, we're going to hear from 4 of the organizations that signed on to our alignment proposal and have been engaged participants in our state transformation collaborative over the last 2+ years. During our discussion, they're going to share their experiences being a part of the State Transformation Collaborative, why they decided to sign on to the alignment proposal, and how it can be helpful for their organization to join this initiative. So I'm going to introduce the panelists as folks can walk up to the stage here. So first, Dr. Tom Roth is a practicing family physician and the president and CEO of Community Care of North Carolina. Dr. Mark Gwynn is the Chief Value Officer of UNC Health and the President and Executive Medical Director at UNC Health Alliance. Jess Kuhn is the HIE Medicaid Services Lead at the North Carolina Health Information Exchange Authority, which is the agency that operates North Carolina's state-designated health information exchange, North Carolina Health Connects. And last but certainly not least, Dr. Jeannie Comivez, a family physician and the Chief Medical Officer of WellCare's North Carolina plans, including their Medicare Advantage and Medicaid plans. So thank you all for joining us. I'm going to shift around here to the chair in the front. And I will pose a question to all of you to kind of kick us off here, which is, why did your organization decide to participate in the State Transformation Collaborative and sign on to the alignment proposal? How has the North Carolina State Transformation Collaborative advanced work in your own organizations and toward those goals of high quality and whole person care? So Jeannie, maybe I'll start with you since you're sitting next to me.
Great, thank you. So the saying is, if you're not at the table, then you're on the menu. And representing one of the Medicaid prepaid health plans, obviously we want to be at the table, right? We don't want to be on the menu. We are frequently on the menu, but that's okay. But no, the opportunity to be at the table and to hear the discussions, to be able to get the multi-stakeholder input into quality measures, value-based care constructs, how we can address provider concerns was certainly a key consideration for us. We operate plans in 37 states, and I'm involved both at the national level within the Centene organization as well as locally, and North Carolina has always been just so far ahead. I frequently will hear from our friends at the enterprise level saying, how do you guys do this in North Carolina? What are you hearing in North Carolina? Because they're expecting that they're gonna hear and see that coming nationally as well. And so the ability to take what I've heard from my colleagues as part of the STC work and reflect that to our friends at the enterprise level and shape what we're doing there has also been incredibly valuable. And then really finally, and this goes to Rebecca and everybody that's been working on the STC, right? I think we've all shared a lot of input and feedback along the way. I think it's been a really great open dialogue. Sometimes I know I can get loud, and I know my colleagues sometimes are willing to speak up as well, but I think it's a real testament to the work that we've done that there has been the ability to incorporate that feedback as we've moved along into an alignment proposal that all of us felt comfortable signing on to. So congratulations to the hard work of the folks at the STC, and it's been exciting to be part of it.
I appreciate that, Jeannie, especially the translation to what's happening in other states. But Jess, I'll come to you.
Yeah, sounds good. Hello, everyone. Happy warm afternoon. Really echoing what Jeannie said, I think one major thing that we've loved at the HIEA from the STC is really just the environment to collaborate across different stakeholders that represent the different payers and folks that we serve as the statewide health information exchange in North Carolina. We're in a really lucky spot here in North Carolina that we do have a state designated health information exchange. A lot of our other state partners either don't have a single data aggregator in the state, they have multiple regional ones, or they do, but they might not have as close of a relationship with the many stakeholders that serve across the health and human services in North Carolina. The STC has really just provided an opportunity for us to discuss very candidly the difficult things that we're all dealing with, from quality measures to exchanging health-related social needs data, and is just directly aligned with what we're trying to build at the Health Information Exchange Authority. We have recently published our 2030 roadmap at the HIEA, which has 4 large strategies broken out into over 60 different objectives for how we're going to meet those strategies over the next few years. And a lot of that, when I read through that and look at the alignment proposal, there really is just direct synergy in the work that's going on. And so overall, I think we just really appreciate the STC as an avenue to not only discuss these difficult things we're working on, but then to have sort of that information discerned into the alignment proposal so that we can take that into the next step of implementation.
Yeah, great, thank you. I couldn't agree more. We were engaged from the beginning for a couple of key reasons. I think first, value-based care, value-based payment models, whole person care, to me, is just simply what we should be doing. So the opportunity to normalize that in North Carolina as our common future and goal, we can't pass that up. So to your point, we wanted to be in the room at the table. This gave, from a health system standpoint, when during times of financial instability or fiscal uncertainty, we often tend to focus on the near term. And we make sometimes myopic decisions. And this gave a venue for us to really keep the focus on the future and keep the momentum going, even internally. I'll give you a prime example. We have 10 system organizational goals at UNC Health. 3 of them are related to quality. 1 of them is hypertension. It was actually quite easy for me to sit in front of my colleagues across the system to say, everyone in North Carolina thinks that hypertension matters. So taking that alignment and making it real, again, taking that opportunity, that window of opportunity is really important. And then third, just momentum. It's not dissimilar, Jeannie. I talk with colleagues at systems across the country, and they always ask, what's going on in North Carolina? How are you doing that? And I think it has to do with collaborative effort. To me, collaboration and collaboratives like this are critically important because all stakeholders matter. It's much easier for me to understand someone else's perspective if I'm at the table talking about what the barriers are collectively, individually, and then creating a path forward and finding those windows of opportunity where they overlap and jumping right through. So to me, that was really critically important.
Yeah, and for us, CCNC is supporting network called Community Care Physician Network, about 500 practices, 1,000 sites across all counties. And a lot of it was the timing. We were about 2 years into Medicaid managed care, Blue Premier had launched, and we were just seeing really this massive gap in the infrastructure to report and extract and report data and the administrative burden, all the things that the collaborative is working on. So the timing was important, and it was really, I remember that first meeting was incredibly unique. You had CMS, you had commercial and Medicaid and, you know, Medicare essentially there. You had different types of provider groups, all different stripes. You had the state leadership, and the secretary really came in and laid down the gauntlet and said, I want you all to get something done. And so it just seemed, I think for all of us, a really unique opportunity to move the ball down the road, so to speak.
Yeah, I really appreciate that. And so I think that certainly the leadership at the state level has been critical in driving this, and those priorities that you've all outlined within your own organizations is ones that we have sort of funneled in through all of your input and everyone else's into the State Transformation Collaborative, and trying to go farther, faster together. So Tom, maybe I'll stick with you for a minute, and just wanted to call out, you know, the critical input from CCNC's perspective and engagement with the STC and helping shape kind of our specific focus around data sharing infrastructure. And so what do you see in the alignment proposal that can help some of those data sharing challenges that you were just alluding to among independent primary care practices in particular across North Carolina?
Yeah, I'll kind of jump off from the same place. We work across 52 different electronic health records, and we had this very expensive, labor-intensive experience of extracting and reporting across multiple measure sets. Mark, you've talked a lot about, I've got 100 different measures that UNC is tracking. So, the opportunity really to do measure alignment was the incredible amount of energy behind that. And then I think the second thing around administrative burden is the effort to standardize a supplemental data submission. That was a great effort, kind of low-hanging fruit. Let's just have one format to submit across all the Medicaid plans and hopefully to others. So those have been incredibly helpful to us, and were probably the highlights. And then I think one of the pieces that Rebecca highlighted in the proposal is really a collaborative effort to support those small, independent, rural, under-resourced practices that just don't have the infrastructure, and how can we leverage the HIEA and other partners to advance their capabilities.
Absolutely. And actually, maybe we'll use that as a tee up for you, Jess, to kind of come back to some of the things that you were alluding to and your engagement with supporting digital quality measurement through the HIE in collaboration with Medicaid, as well as the health-related social needs screening data. How do you view that STC as kind of building on a lot of these efforts that are in your strategic roadmap, and you know, how can this group help inform the directions that you all are taking?
Yeah, so we've been working really closely over the last few years with NC Medicaid on work related to a few different use cases. The first being the digital quality measures use case, or DQM use case. We know that CMS is planning to transition all of the quality measures they're using in their reporting programs to digital measures in the future. And so that use case really stemmed out of us just trying to get a little ahead of the game and prep NC Medicaid for what was to come in that space. Through that, I think we've, as I think we all know in this space, uncovered a lot of different things as we're sort of lifting up rocks, you know, or peeling back layers of the onion. And so this started out as what infrastructure do we need to build for being able to run digital quality measures, and has quickly evolved into a larger work effort to improve the quality of the clinical data that we're receiving at the HIEA, as well as be able to expand our participation in NCQA's data aggregator validation program so that our health plans across the state are able to use quality measure data rather than doing chart chasing and requiring supplemental data submissions from their partners. So that has sort of evolved into this larger DQM use case that we are working on. Similarly, we have our health-related social needs screening use case, or HRSN use case that we're calling it, where our main goal is just trying to build a system where we're collecting the HRSN screening data that we know is currently happening at the provider level, at the health plan level, at the community-based organization level, and being housed in all of these disparate and often siloed systems, and making that data available for the appropriate entities and appropriate permissioned users to view. These screeners are often really sensitive questions that are being asked, but they're often being asked multiple times. So that leads to not only having duplicative information, but then sometimes there's information about a member, for example, being screened for food insecurity and showing up positive for that, and not being connected to the resources that may be available to them because, one hand doesn't quite know the information that the other has. And so what we're trying to build is a system where we at the HIEA can kind of serve as the connective tissue among these different organizations to share that information back and forth. Going back to sort of the DQM use case as well, I think our priority measures are directly aligned with what we've been working on at the State Transformation Collaborative, two of which are the controlling high blood pressure and the glycemic status assessment measure. We're also interested in exploring more about the screening for depression and follow-up measure, because we know that's another one that's extremely important for both our adolescents and adults in North Carolina. And so both of those use cases, we've actually recently launched what we call our HIE Medicaid Services Early Adopters Program, where we're inviting participants, specifically provider organizations, to come to the table with us and work through these two use cases. And they're actually eligible for incentive funds for this work. And that's due to the partnership we have with NC Medicaid. Those funds were able to be pulled aside for this work specifically, which I think just underscores the commitment in North Carolina for this work to be able to drive it forward. We know that there's a heavy lift at the provider and practice level to look into the data quality of clinical data, to help us set up these feeds to transmit and standardize health-related social needs screening data. And so we're not only asking folks to come to the table and work through that with us, but also able to provide some sort of compensation sort of after the fact for that. So we're really excited for us to be able to continue working on this. I think the STC has been a great venue for us to sort of chat about what progress we've made to date, share those lessons learned, and then also hear about what work is going on in the other spaces that we might not be as in tune to, and see how we can collaborate across different agencies. I think we've walked away from plenty of the STC meetings and work groups sort of with a action plan to collaborate with different agencies and bring other folks to the table. So overall, I think it's just been the venue for being able to have these conversations that sometimes happen in these siloed spaces.
Yeah, absolutely. Really appreciate that, and was thinking about, building on some of Tom's comments around support for small, under-resourced and rural practices, and how exciting these opportunities are, that the collaboration that you all have with Medicaid is to kind of bring some incentives to those organizations and help engage folks in those data quality conversations. And then I think building back on your health-related social needs use case, a couple of things you said, we heard a lot in our discussions with the STC related to kind of repeat screenings for folks that are adding to the burden and also the trauma of being asked these questions. And then I think that also points to some of the data quality pieces of, if organizations are screening individuals, are those data being stored in a way that they could be shared so that we can kind of decrease the amount of repeat screenings and ensure those folks are then who receive a positive screen and express an interest in being referred on can receive those referrals. So those will be two big focus areas for implementing the alignment proposal of the STC as well. But Mark, maybe I'll come with you, to you to kind of pick up on some of those threads. You have been involved in a lot of these pilots with the HIE and kind of testing the sending of data, including the health-related social needs screening data. And so given, UNC represents sort of a mix of both large and small practices, what value have you seen through the STC kind of for helping shape the collection, sharing, and use of health-related social needs data? How does this build on kind of things you're already doing and to improve those data, and kind of where do you think we can be focusing in the future?
Yeah, first of all, we were really grateful to be part of the pilot, so thank you. One of my teammates described it this way, that if there's a river and you have 100 people that come up to this river, everyone's going to jump in and try and swim across, and they're just going to figure out how to do it. But if you lay down a bridge, suddenly you don't have to worry about getting over the river by yourself. You can focus on everything that happens before you even get there. And that's what this feels like. And so when we have standardized screening, standardized connecting systems, suddenly we can stop paying a lot of attention to the how, and we can focus more on what the data is telling us, and how we can connect the right resources. So I'm now really interested, and it's a little early to say it's totally effective. I have to channel my VP who said that. Very data-driven person. But it's really is promising. And now I can say, what resources does Jeannie have to apply to X patient in X region that I don't have to duplicate to serve the same patient or the same subpopulation in X region? So getting back to decreasing administrative burden, suddenly we have a way to really start to allocate the right resources and not duplicate and rely on each other across North Carolina. To me, that is incredibly promising. And reduce it, and therefore I can focus on a larger population. The needs will outstrip our resources all the time, but I think maybe we can serve more people now. And then secondly, I can start to turn all that data and effort not on making the connection, but on characterizing the entire network as to where the resources are needed, not just who can provide them, but in rural areas, which practices need X versus Y, which regions need X versus Y. And again, we're generating a ton of demand. So now we have to be really careful about where we allocate our current resources. There's some early evidence it's starting to work. We're generating a lot more demand, 342% increase in referrals for food insecurity over the past 3 months, a 380% increase in referrals for financial insecurity in the past 3 months. And we had, I just saw these numbers yesterday, that's why I know what they are. And we had 11,100 referrals for health-related social needs in May alone, both coming from patients who have been screened, from practices, from care managers, from the ecosystem that is now surrounding these patients in need in very different ways. To me, that's tremendous progress. Now we can focus on getting work actually done.
Yeah, and I think kind of building on the evidence as you suggest to kind of focus allocation of resources where they're most needed, but then also trying to underscore, what works best and for whom, and kind of generating a lot more knowledge out there on kind of the evidence-based practices in that space. Jeannie, I'm gonna come to you next, given that you kind of straddle both a state-based health plan with kind of a national imprint. And, we've certainly worked through the STC to align our work both with federal initiatives, as well as kind of, state-specific efforts, in an effort to accelerate progress. So from your perspective, as a plan and business across multiple states, how does this influence your ability to kind of sign on and engage in this work? And then to your point earlier, sort of take lessons from North Carolina and apply it in other states?
So I think one of the things that we don't often think about is for the national payers that have plans in, I think for us it may be 37 markets, and forgive me if that number is not exactly correct, but it's close. And we have Marketplace, Medicaid, and Medicare Advantage plans. And if you can imagine the complexity as a national payer with 37 different, or 32 or whatever it is, Medicaid plans, all of whom are managed by different state regulators with different priorities, and frankly, picking different quality measures, right? And how do we manage that from a national level to create dashboards and data and analytics and results and all this, because we've got to be able to tell our providers how they're doing and make sure that they've got the data that they need. And North Carolina is going to be different than South Carolina is going to be different than Georgia, right? So we actually have been working for several years to try to create alignment at our national level around quality measures and value-based contract structures. And really great that the STC actually kind of came in for us at about the same time that we were really ramping up that work. And so I've been able to have a good bunch of conversations with Dr. Alice Chen, who's also a co-chair of the Healthcare Payment Learning and Action Network Executive Forum. And so she's hearing about stuff at the national level about what we're doing here and coming to me and saying, how are you guys getting this alignment? How are you moving forward? How can we replicate that kind of effort at the national level and across the multiple states that we operate in? I would say we've made a lot of progress. And just like our STC collaborative, it's taken a lot of creativity and a lot of compromise. And I think we've come up with something that's probably going to work, and we're really excited about it, but it's like building that bridge, right? We're going to get halfway across and make sure that it doesn't fall into the stream. And then, you know, I've also had the opportunity, not only working within our enterprise quality measure and VBC clinical advisory group, but I'm also sitting on the CQMC, the Core Quality Measures Collaborative steering committee now. And so I'm also getting to hear about how do we align measures from that viewpoint, right? And they bring in providers of all different specialties into specialty focused advisory groups. They look at a core measure set. What do they want to add and subtract? And their focus always is, we don't want to have too many measures, right? But then you look at the list of measures and it's like, yeah, but that one just, like, we don't really want to eliminate it because it feels kind of important, and trying to strike that balance. But I think my sense is everybody wants to, right? That's the goal. And then the question is how much to align and how to align and where to align and how can you strike that balance between too much prescriptive alignment, which frankly in Medicaid won't work, right? Because we've got all the different plans with different regulators and different priorities. But to get enough alignment that it's not crazy making for the providers that we work with.
Yeah, I think, and we've kind of talked about those in terms of directional alignment and to your point on, so, you know, alignment, but with some flexibility. And then where is deep alignment really helpful, where you maybe are more prescriptive and trying to figure out what are the use cases for each of those. I think we have time. I'm going to come to each of you maybe with one more question, and I'll tee up for folks in the audience, both online and in the room. We're going to open it up after this for some questions. So feel free to raise your hand if you're in the room, and we'll run a microphone over to you, or you can submit questions via the Slido interface as well. So just a question for all of you here, and that is, you know, as we think about moving from, we've put in an enormous amount of work, you all have, and representatives from your organizations have been engaged in this process, and an enormous amount of work to reach where we are now with the alignment proposal and the kind of conceptual agreement on our key alignment opportunities. As we're thinking about moving into an implementation phase, you know, what advice do you have, and what do you hope to see through the STC in this next implementation phase of the work, and really kind of doubling down on this cross-sector collaboration that we've been able to build, and some of the value of that. So Tom, maybe I'll start with you.
Sure. Well, I would say there's really this importance of being a convener. So what Duke-Margolis is in that role now, but there's something about the human element of us connecting in this neutral space to advance some, you know, really important policy initiatives around, for us, the survival of primary care, that, you know, value-based care is no longer a side hustle. It's central to the survival of independent practices that are critical for the infrastructure in North Carolina. So there's just being in the room together and connecting, and, you know, just thinking about one of the debates around the combo 10 and removing that from the proposal, that debate couldn't have happened on Teams and, you know, in a different space. So the importance of you all as a convener will be critical moving forward.
I like the value-based care is no longer a side hustle. I think we're gonna.
Gotta put that in.
It needs to be, we should add that.
Tom, I fully agree with you. The role of you all being a convener is just critically important. It's how we understand each other's perspectives. That's how we get over barriers. I do hope, one, the work's not done, so we have a lot more work to do, which is great. I think kind of the next iteration, perhaps we can think about how to accelerate prospective population-based payment models within North Carolina collectively. I think our ecosystem has changed over the past decade and even the past 5 years. Maybe we're ready or we're close to it. So I'd like us to think, how can we collectively accelerate that a bit? One of I think the values that a health system brings to this work is access to high-value specialists. So I would be really interested in figuring out collectively, how can we incent primary care and specialty coordination better than we have in the past, especially in rural areas, providing better access to find high-value specialty care in areas where it doesn't exist or it has limited access. We get a lot of referrals, and some of them are necessarily and a lot of them aren't. So we can extend those resources differently. Perhaps that's something we can think about. And then to align with some of the priorities around what our federal colleagues are focusing on now too, and especially around AI and technology and how that impacts patients specifically. That's such a space here that we are all diving into in probably 50 different ways. I wonder if there's a space where we can align on some kind of technology that helps all of us and define what that is and potentially promote that to each other.
I think expanding on that a bit is sort of what both of you have already said. We've laid the groundwork where we've created a sort of circle of trust within the STC. It's really easy, as I already mentioned, for us all to sort of go back into our silos and sort of work on all of these different initiatives. And what is it from our perspective, for example, at the HIEA, that we think we can be doing to improve the population health in North Carolina and data sharing? But coming together and being able to speak with folks across all of these different organizations is such a unique opportunity that when I talk to folks from other states or other agencies, this is really unique. Being able to carve time out of folks' schedules, come together and talk about these sort of troubles or things that are sort of giving us pause and how we can strategize to move forward. So I would argue that we've actually done the easier part, and now is the tough part, right? We actually have to implement on all of this laundry list of items that we've kind of identified as what are these opportunities for this alignment. And so how are we going to drive this forward? I would say that I think moving into the future, this is only going to become more important, this forum, to be able to continue testing on these different strategies we've identified, test that bridge, make sure it's strong. If not, come back and, it's part of the quality improvement process, being able to talk about what's working and what's not working and how can we move forward. So I'm just really excited for the future. I think we've laid such a strong foundation. It's only going to help us moving forward.
Last but not least, yeah.
I am so excited you mentioned high value specialty care. And I mean, Larry, that was something that I know you and I worked on when I was at Duke. I think there's huge opportunity there, and I think we ought to put that on the list of things that we talk about, because we don't use our specialists efficiently and effectively. And we know there's ways that we can really improve that to the betterment of primary care, because we don't want the primary care doc out there worrying about not having the right information to take care of a complex patient. And we've got a specialist sitting somewhere in an academic health center who could help them, but they can't get connected. So I think there's some great solutions for that. And then the other things that I put on my sort of forward thinking list are the data access, and particularly, like, we've got measures now, how are we going to measure progress on them, right? So we get the data and we've got to make sure that we're actually improving what we set out to improve. What are the other provider supports that we need to facilitate that progress, right? And I know my organization has been trying to judiciously support practices with some of the data infrastructure over the last year. but we can't do it alone, and we've got to figure out what the providers need in order to really help them do that. How do we reward the good quality work, right? When we see the progress, how do we make sure that that's rewarded and incentivized? And then there's the standardized provider incentive program for Medicaid that's out there now. And I would love for us to take a good hard look at that, kind of under the umbrella of all the other work that we've done as part of the STC. And see, you know, how do we move that forward? Is that exactly what we need? Are there other ways that we could improve it? But to kind of put that into this work as well.
Well, that's great. I think you all have outlined a lot of important things for us to consider and bring to the table as we kind of continue these discussions. And as Jesse mentioned, you know, the hard work isn't over. We still have a lot of work to do. And I think you all have underscored really the importance of having in-person and neutral spaces to have these conversations, bring some of these shared challenges and priorities for further work together. Think about how do we do those pilots and build the bridges so that folks can, you know, do the planning in advance and cross the river more easily. And now I'm going to try and work in the side hustle comment as well. You know, making it kind of the featured performance on population-based payment integration of specialists and the like. So I think really appreciate all that you all have contributed to these discussions over the years, and looking forward to continued collaboration. And you've given us our charge that will kind of continue into the next panel for today and our fireside chat as well. So I think maybe let's give a round of applause to our about 5 minutes here for questions. So I see one that was submitted online that I will attempt to address first. And one question was clarifying whether the supplemental data file layout has been standardized across all the Medicaid health plans. The answer is no, and panelists feel free to chime in here, but that is something that we are working on through the STC as we enter this kind of implementation phase and trying to identify what are the differences in, and I'm looking at Jessie here because she's been leading a lot of this work as well. But what are the differences of and all the different templates that providers are submitting to plans? What are the key things that plans really need to see, and how can we streamline that so that providers aren't slicing and dicing in a bunch of different ways to submit to the plan? So exciting things to come there, but not a done deal yet. Oh, question, well, I don't know if anybody up here would like to add to that.
We're ready to roll up sleeves and.
Yeah. I asked our quality folks, like, you know, what are we doing, right? Because I'm not in the weeds doing that work. And they're like, if the provider wants to send us data, we'll take it in any format that you want to send. And I mean, the question is like, on which end is the work being done, right? We can take it in and normalize it, or the provider can have to normalize it to our panel or to our format. And we're trying really hard to be like, whatever you want to send us, just send us and we'll figure it out. I think the bigger challenge is the data quality auditing that has to go on as part of like the NCQA, right? So we can take the data, but we get the data, but then we've got to actually audit the accuracy of the data before we can use it. And that may in fact be a bigger burden than just the data format.
Yep. Yeah, absolutely. I'll come to the room next. I see somebody with their hand up. Sure.
First of all, I just want to say I'm just incredibly impressed by the collaboration and spirit that the old process. A lot of time in a lot of other states where there's an awful lot of contentiousness. So it's amazing to see this sort of cross-sector collaboration. I haven't been in North Carolina since the late 80s. So clearly, you know, that was a mistake. I should spend more time. My question is about patients. Obviously, a lot of talk about administrative simplification, deburdening, data sharing, and so forth. What I didn't hear about is patients, kind of how patients plug into this, right? Obviously, you know, patients change health plans, change doctors, change hospitals, and so forth. And as we all know, we deal with a lot of administrative friction ourselves as patients. How do you see patients plugging in to this work and benefiting from the, you know, kind of this framework that you put in place?
Absolutely. I can, yeah. Who would like to?
Happy to start unless you want to. I was just going to mention for the health-related social needs work, for example, that we're doing, I mentioned that we're trying to sort of standardize the information that we're collecting and make that available within our NC Health Connects system. And so not only would this reduce burden on the patient who is potentially answering questions multiple times, but will also help connect them to resources by giving those folks, for example, that have access to our clinical portal, the information they need to be able to connect them to resources. So I think there's opportunity there to be able to support patients in that space. I think when we think about the quality measures space, one major thing that we're trying to shift towards in NCQA is moving away from these sort of hybrid, more population-based measures into more individual measure specifications so that we can start looking at closing individual care gaps. And so being able to rely on the increased high quality data within NC Health Connects to be able to see which of my patients with hypertension, for example, have a controlled versus an uncontrolled blood pressure, which can then lead to more targeted provider outreach or initiatives in certain areas where we might see more uncontrolled hypertension amongst certain populations. So I think there is a lot of direct impact to patients when we think about those two initiatives specifically.
I completely agree, and I'll even take it up a level. As we're reducing burden for our providers, yes, it's a focus of much of our work at this collaborative. It allows our providers to care for more patients, quite honestly, and on a deeper level. It's through this work, redefining what the care team has been really important. We can't address the needs that we're identifying without additional care team members, and that's become normalized as well. So we can go deeper into the true causes of poor patient outcomes, particularly health-related social needs. As I mentioned before, we know a lot about our patients now, a lot more now than we did in the past. Now it's incumbent on us to design the solutions and the interventions and the resources. And that's fundamentally different. I always make the analogy to depression screening. Years ago, we started screening for depression, and guess what? We found it. Then we had to design interventions to really manage that. And I think we're in the same space for health-related social needs, which is just foundational. And to me, that's a very different patient experience coming to my office or the offices across our network. They're seeing and being asked and receiving resources and care just differently than they were 5 years ago, or even 2 years ago. And to me, that is really whole person, patient focused.
So not that long ago, I sat on the provider side of the world and was part of population health at Duke. And we would get these data files from our payers saying, here's all your care gap issues, right? And we would actually do a deep dive on them and find that a good bunch of them weren't actually care gaps. And the reason was we knew more about our patients and they knew about their members. And so one of the things I'm always thinking is, let's not give the providers data that they probably already have, right? We want to make sure that we've got that data all in one place and it's accurate. And it includes the administrative data that the payers have and the clinical data that the providers have, and put it all together and rationalize it so that when we say there's a care gap, it's a real care gap. And otherwise what happens is the patient member gets a call from the plan 5 times about closing that gap when the provider already knows it's closed, right? And there's nothing more annoying to patients. And we actually hear complaints from patients. You guys are calling me too much.
Yeah.
Leave me alone. My doctor's taking care of it. It's like, okay.
So Kiva, I think that's a good chart to kind of, how are we keeping the patient at the center of all this? So appreciate that. And we're going to shift now to our next session, but really do appreciate the questions that folks are submitting and some good thoughts about how this group can help with expanding primary care access and workforce strategies as well. So lots to think about there, and appreciate your questions, and many thanks again to our panelists.
I know people probably want to stretch their legs a little bit right now. We are going to continue on with our program, though. You're just going to be hearing about me for the next couple of minutes. That's probably the least critical part. I do want to introduce the rest of this session, where we are going to be focusing on looking ahead. So how do we take the progress that's been made already across the participants in the State Transformation Collaborative and all of the other organizations, people that have been working with us in this process to build on the progress to date and move forward. So you heard about from the last panel and Dr. Whitaker and her collaborators that went into this, where we've been so far in terms of starting to make a difference. Mark, I really like the bridge analogy, and it is a big challenge to get through our healthcare system today, let alone to get to a healthcare system that really is focused efficiently on identifying, helping people address their risk factors, medical and non-medical, and avoid complications, keep costs down, get to better health outcomes in the state. To make those connections, we can all build our bridges or try to individually. That's really hard as an individual patient or an individual health plan or a provider. But it's great to see that when we come together, we can start, I'm not sure the bridge is a fully functioning multi-lane highway yet, but it is great to see the identification of people with risk factors and ways of bringing data and analytics to bear on helping address those needs as efficiently as possible and tracking the impacts on healthcare costs and outcomes for North Carolinians along the way. So looking ahead, this alignment proposal to help us get to this point was really the first phase. As you heard from Rebecca and the rest of the panel, everyone is already thinking about advancing implementation. The proposal itself outlines some of these steps in areas like supporting goals for specific goals for improving population health. Here, those have included non-medical needs. They've included issues like difficulty controlling chronic disease risk factors. So we'll see more of that, I expect. There is growing interest in using the improving electronic health data interoperability, and associated digital health technologies and AI to make more progress in reducing burden on individuals and finding their way forward, on healthcare providers, on health plans and healthcare providers working together and bring to bear information from social programs that are set up to help people address some of these non-medical needs as well. And very important for all of this, as you heard from the last panel, is healthcare purchasers, employers, healthcare payers, health plans, and the providers working together to support people, putting people more at the center and in more control of their care. So those are some of the priorities that we're working on. And to talk more about this, I'm going to bring in some new perspectives. So those of you who are in the room for this panel, come on up. We're going to be joined virtually by Will Gordon, who's Chief Informatics Officer at the Centers for Medicare and Medicaid Innovation. Will's a physician and serving in this role now for some time, making a big difference in the federal side of advancing these data and technology issues. Also with us, Dr. Charlene Wong. I think, yes, there's Charlene, who's Associate Professor of Pediatrics and Public Policy at Duke and a former Senior Advisor for Health Strategy at the CDC. Welcome back, Charlene. And we very pleased to have with us Tom Friedman, who's Executive Director of the State Health Plan. This is a new role for Tom, someone who's been making a difference in a range of issues related to improving care, and now a big challenge with affordability of employer insurance for the state's employees, retirees, and their families. And from North Carolina Medicaid, Dr. Janelle White, who is the Chief Medical Officer there and is focused on overseeing quality population health and clinical programs, not a modest portfolio. Janelle, thank you all all four of you for taking time to be with us. And I'd like to start out with a general question for the group. So you all in one way or another have been involved with the state transformation collaborative efforts here, and in Will's case, efforts to collaborate to advance value-based care, reduce the burden of care, improve affordability and health outcomes with data and technology nationally. Based on what you all are seeing in the current policy and healthcare environment, where would you highlight opportunities to increase the impact of this collaborative work here, and maybe provide some examples or guidance or insights for what's needed nationally in these areas? I'm going to start out with Janelle next to me, and work in the rest of you too. Janelle, thanks again for being
Yeah,
here.
thank you. I appreciate the opportunity to participate on the panel today. I appreciate the work of the collaborative. You know, I think that where we are now, the progress that we've achieved just highlights the importance of collaboration, highlights the importance of sort of having a unified voice, you know, around issues that are paramount to the health of the people that we serve, as a provider, as a payer, you know, in whatever capacity that is. I think that this is a very integral for us to continue to make progress in that space. And for me, I think sort of next, to answer that question, it's important for us to continue the collaboration, right? And to maintain this momentum. I think that that is very important. Also, spoke to this a little bit. One of the questions was around patients, right? You know, so that is also something to consider, right? You know, I think that we in various forums find our ways solutioning for people, and their voices not always at the table, right? So is that something that we make sure that we are intentional about, maybe not in version 2.0, but at some point in the future, you know, that just may be something to consider. And then also just looking ahead with our collaboration, you know, for me, I think the next step to maximize impact is we have aligned internally. So, you know, I know in a lot of spaces we say we want to democratize our data, right? And make sure we have access to it. I think I see it along the same vein, democratizing the work of this collaborative and making sure that these great ideas do not stay in this room, don't stay within the walls of the collaborative, right? But making sure that it is applicable, is relevant, is meaningful to the field across the state. So that is really our great opportunity, is to sort of making sure that we are aligning outside of the walls of the collaborative. That's very important for me. And just making sure that we're translating these ideas in our identified priorities in a collaborative way that reaches all corners of the state, right? All different types of providers, types of provider types. I really think that that is our opportunity at this point.
Great, great points to come back to, Charlene.
Yeah, well, thanks so much for having me. It's so great to be back at Duke. So because I just came from the CDC, the area that I wanted to highlight for the STC is to really lean into that evidence-based prevention. And Mark, you asked about the current policy environment. And certainly one of the things that is particularly concerning right now, or there are cuts proposed all over the place. Obviously, there's a lot of attention on proposed Medicaid changes. There have also been substantial cuts already made to public health, as well as additional ones proposed. And so when thinking about the STC and the, as Jess called it, the circle of trust, you know, that's already here, right? It's like the type of partnership between public health and healthcare. They're going to be so critical, because I don't think I have to convince anyone in this room that that partnership is so incredibly important. We're interwoven threads, and you pull on one and both, you know, the other is weakened, and instability and performance in all the ways. I will give you a sneak peek. I've actually been working with a group called the Common Health Coalition, which is an organization of multiple national payer and provider and public health organizations. And we have a report coming out very soon that is outlining some of the consequences for healthcare of these public health cuts. And I'll just give you a sneak peek into the framework of how we're thinking about this, and hope that this is maybe useful to some of you all in the room and to the collaborative. So the first is we're going to have fewer services for our patients and for those of us who are clinicians. Things like, I refer to the tobacco quit lines. I'm sure many of you all do too. Guess what, friends? All that funding gone from at the federal level. And so at some point, state level run tobacco cessation quit lines are also going to go away. Those of us who send out labs to our public health labs around things like tuberculosis sensitivity and, you know, oh, I wonder if this is H5N1 or not, right? Like, that lab infrastructure is also under threat. The second is, of course, we're going to see more sicker and thus costlier patients showing up to our healthcare system. You look at, there's been huge cuts proposed in the HIV space. And I mean, that's going to cost billions and billions and billions of additional healthcare dollars if all of those cuts remain in place. But the third area is, listen, these are not inevitable consequences, right? There are partnerships, there are opportunities to think more creatively about how we fund some of these services across public health and healthcare, but that will likely involve healthcare, both payers and providers making choices of, okay, do I backfill some of what is now gone because it's not available from public health, or do we go without? And I know we've got Janelle here and some of our other Medicaid friends, working with NAMD and some Medicaid leadership in other states. For example, in our vaccine infrastructure, there are other states that have figured out how to use Medicaid match dollars for their immunization registry systems that have recently lost some of the funding that they're using. So I think, coming back to that circle of trust and thinking about how in this moment, with a lot of uncertainty and cuts proposed on many sides of the health ecosystem, not to forget about that public health front and how there's just going to be these ripple effects and how the STC can really be part of the solutioning because of the collaboration.
Okay, I'm going to ask you a follow-up question on that in a minute about what does the STC do next in this environment. Let me shift to Will, just to remind people, this is a combined virtual and in-person panel. Will, you've been working for some time on trying to get to real consequences from CMS and federal policies on healthcare data interoperability, supporting incentives, all kinds of things that are intended to make healthcare and the goals of the State Transformation Collaborative here easier to address. I appreciate your thoughts about what's next.
Great. Thanks, Mark. Hopefully folks can hear me. Thank you for inviting me, and sorry I can't be there in person. It is 102 degrees today in Boston. So maybe it's cooler there, maybe not. So a couple things to highlight. So I think that we've done a bunch of policy work recently and over the last couple of years that are worth mentioning. And I think the first is around prior authorization. So CMS last year finalized a rule that for regulated payers, folks, payers we regulate, MA plans, CHIP, et cetera, requires a bunch of new processes around how they interact with prior auth, especially from a data and standards perspective, trying to improve transmission and workflow around that. So some examples include requiring APIs that list covered items and services, requiring APIs to give an approved, denied decision, really basic stuff, along with timelines. And so this has been a big CMS initiative. Dovetailing on that is an announcement that we actually made this week in conjunction with AHIP and a bunch of other large national payers to where they made voluntary commitments to improve both technical as well as process aspects of prior auth. And so I think really leaning in on how we can make something that is so clearly an administrative burden better for all the stakeholders, especially for patients who often end up without care. So I think prior auth is something worth highlighting because I think it may be relevant to the STC, especially for local data infrastructure. The second policy initiative I think worth highlighting is that we've spent a lot of time and done a lot of work to improve access to data, especially administrative claims data. So that same final rule I mentioned before also includes new provisions expanding patient access to their claims data, as well as provider access to data. So providers should be able to access their, for patients they have a treatment relationship with claims data for those patients via an API starting in January 2027, and then a payer-to-payer API. And this came up in the last session. How do we facilitate the movement of patients between health plans? And this API should facilitate that. It's an opt-in API. And the third policy initiative to highlight, also very recent, CMS recently published an RFI seeking public input on how to advance a secure, interoperable, seamless, patient-centered digital health infrastructure. This RFI closed last week, 1,300 responses. So obviously we're sifting through that pretty aggressively right now. But as part of that RFI, we made a series of announcements at a listening session a couple weeks ago and commitments that for the coming year. The first is to build a national healthcare directory. So providers first, a single source of truth for provider data. the value there is clear, I think, but we did make that commitment. We also committed to moving towards modern identity solutions. So things like Clear, login.gov, state-of-the-art ways to just prove who you are as a patient or provider. We are moving towards digital insurance cards, so giving beneficiaries real-time access to coverage information, not relying on just something you get in the mail, every year, every 2 years. The fourth was expanding access to another one of our APIs called data at the point of care, which gives providers access to their claims data. So kind of what we regulated for other payers, us doing that as well for patients and providers. And then finally, us participating in trusted data exchange. So I just said a lot, and obviously happy to dive into any of those, but just highlighting that from STC perspective, there's a lot of data and infrastructure work that CMS is trying to lead, either through policy, rulemaking, programmatic, technology investments, or even just convening. And I think a lot of that could be informative to STC priorities over the coming year or so.
Great. Thanks, Will. Definitely a lot to come back to there as well for the coming year. Tom, you're relatively new in this job, along with the treasurer, Bob Reiner. You came in with just like a lot of employers facing some increasing costs, some shortfalls in funding. I know it's hard to think about maybe some of these bigger picture changes like next year and all when you're worried about how to fund the program for this year, but really appreciate your being here and looking forward to your perspective.
Yeah, I think one thing, well, first letting me go after 3 doctors is always very humbling because I get to be the least smart person here and the newest. I think something when we think about things like the SDC and data is there's no shortage of data in healthcare. And there's no shortage of brilliant people. There's a lot of shortage and agreement and consensus on what is the right answer with data and what is something we could all agree to. I think we spend a lot of time arguing about what is the best measure and what is the next best measure. And is this good enough for an urban person versus a rural person versus a cosmopolitan person versus do we risk score it that way or this? And that's all great and it's all true, but kind of where you let in, I've got 770,000 people's healthcare today that I've got to make sure is funded and solved for. And so there's good intellectual debate, but moving things forward, I think, is also about what is good enough that we can actually take and apply. Looking at the physicians here and the doctors on the last panel we're working with, everyone's got the best ideas and the most well-intended ideas on planet Earth on what to do. But from a day-to-day basis, how are we going to go forward? What is a couple of things we can agree on that are vetted enough and strong enough? So while we're having long-term policy debates, we're doing some short-term action that generates some gains and some momentum going forward. And I think it's interesting, but not as interesting as getting to the right answer. But at the same day, I've got, folks in Yancey County that haven't been able to see an endocrinologist in 2 years because one is too far away. And I don't need a lot of data to tell you it's because it's 200 miles to go to the doctor. It's like, that's the problem. It's, there's no measure of diabetes that's going to say like why they're not in control. It's the doctor's far away. So how do we, while we're doing these things, manufacture access and build on the things that we all agree upon? Humans need more access to healthcare that they will access and is accessible to them. We're trying to do a better job of asking our patients, what do you value from the healthcare experience and what do you value from how you're going to get to the doctor? And then trying to think about how can we partner with, folks who spoke in the last panel, and how do we bring it to them, right? Because I think asking people to drive a lot is not going to happen. So I think the policy discussion is good and important, and we're happy to participate and offer data and suggestions. But also I think the key pieces of going forward is how do we move things a little bit forward so folks have a little bit better access to care and just be okay with we're not going to get it perfect tomorrow. But as long as we're moving in the direction of better, I think that is spiritually where we need to be going.
So how do we move it forward? So I do want to do one round of questions focusing on that. I know our time is limited. Will, maybe I'll go back to you first for this. You talked about a number of steps underway right now that are intended to have some relatively near term, certainly in the next year, impact on how hard it is to get care and also on improving access potentially, how reducing burden, improving access. You talked about prior authorization. That's a big focus for patients and providers, where a lot of it takes place on faxes and back and forth on non-standardized data. You mentioned an announcement that maybe I'm oversimplifying this, but the basic idea is, look, there's some critical clinical information that goes into making prior authorization decisions. If we can find a way to make that more standard and more quickly available between payers and providers and patients, then those decisions should come much more quickly and predictably and at a lower cost. Can you talk about some ways to extend that concept? I know CMS is very interested in, say, if we can move beyond just claims to getting key clinical information or key patient information to move reliably, then payment should be faster. Then supporting data, you talked about data at the point of care to enable stronger primary care. That should be more available. Can you expand on that a little bit about where you see some near-term opportunities that align with CMS's priorities nationally? We definitely in our state transformation collaborative efforts, we don't want to go in a different direction from CMS, but conversely, we think the state could be a leading opportunity to move some of these ideas forward.
Yeah, great. Yeah, thanks, Mark. And I think that it's a great question. I think one potential way to respond, we released an updated strategy a couple weeks ago, or maybe even a month ago or so at this point. And the three key pillars are prevention, patient empowerment, and choice and competition. And I think the patient empowerment one is the one I'd like to highlight in particular. A lot of the conversations I've been involved in around data infrastructure and transparency, HIEs and TEFCA and FHIR and all that important stuff is really focused on payers and providers as the primary folks that are organizations that are engaged in the data exchange. And for obvious reasons, I get it. I think leaning in on the patient empowerment, a big deliberate part of that new strategic pillar is trying to empower patients directly with their data. And I think this is a really important, it's not a change. I think CMS has been trying to do this for a while, but it is a resurgent new area that we're going to, I think, focus in on a lot more. I think that's something I think worth highlighting. I think that this is there's a real opportunity to bring in patients more into this transparent infrastructure that allows them to engage in data. And I think prior auth is a good example of that. So a big part of the prior auth rulemaking we've done is providing analytics, requiring them to payers to actually publish data on their websites around their approval on various metrics there, as well, giving patients access to their data around what has been approved, what's been denied, et cetera. So I think that's maybe one place to think about in particular. Are there opportunities to bring patients in directly as primary engaged stakeholders in these types of ecosystems more than they are today as a way of really accelerate transformation? I think that's CMS has really made that commitment publicly with the new administration. And I think that would be something that would be, I think, a win-win for everyone, and maybe something that it sounds like the SEC is already obviously aware of this, but could be an opportunity for further collaboration and to advance the SEC's mission.
Thanks for that. And Janelle, you brought up in your comments, great that the State Transformation Collaborative have gotten a range of these, I'd say a critical mass, certainly in the payer and the public and the private and employer and provider scope, but we aren't reaching every patient doesn't have easy access to their data and easy access to knowing how to get primary care that they might need, or less costly ways to do it, or ways that take advantage of new digital technologies, kind of picking up on Will's comments. So I know you've been spending a lot of time thinking about what the future of primary care is in North Carolina, particularly for lower income individuals and families who are on Medicaid. Can you say a little bit more about that and maybe tie it back to your earlier comments about how we reach more people, ideally leveraging the data interoperability, the sharing, the common approaches to solving burdensome problems that healthcare has faced for so long.
Yeah, I'm happy to. This is a great call out, William. Thank you for just sort of co-signing on that point about how we bring the patient's voice in, right, and elevate their voice so that we are solutioning with them collaboratively and not for them. And we all know and agree that, primary care is the foundation, the cornerstone, the backbone of any high functioning medical system. I think that we all can agree there. I'm a primary care doctor, so of course biased, but I think that that is something that we can all agree upon here. And it just ties into North Carolina Medicaid's vision and mission of providing, that innovative, whole person centered, and also that the well-coordinated system of care. I think those are very key principles for us as we have these conversations, as we make decisions around the data that we have. How accessible is it for a provider, a payer, a healthcare system to have that data again, so these patients are not burdened with repeating the same information over and over, right? And how can I make sure that the providers that I see have access to the information that they need to be able to make the decisions, and again, that's sort of that co-decision making, right? How can I participate in the decision making if I have access to this data? So that's certainly a point, that I think that, sort of looking ahead and looking around the corner, something that we can continue to think about and add to this collaborative, also in the innovation space, and sort of touching upon the principles of Medicaid with innovation, the whole person centered, and the well-coordinated care. If you look at our Healthy Opportunities program, that where we look at the health-related social needs, I just, as a provider of practice for about 20 years, and maybe 10 years ago, this was almost a foreign concept, right? It is fascinating to me how, this for me removes that feeling of defeat, right? As a provider, if I get this information, I don't even know what to do with it. I don't know how to help anyone or connect them. So, for me, I see us continuing to move in that state and other areas that we prioritize. So, just continuing on this momentum of putting the patient at the center is very important, and something that I encourage and challenge us as a collaborative to be mindful of as well. We're all facing headwinds, budget, environmental, in the healthcare system, we understand the margins are thin, right? We've been in that space, but keeping that person-centered approach at the core of what we do and sort of rallying around that and staying committed to that. I think that is very important, and that will help us keep the person in mind who is the end user of these strategies that we are putting in place. But again, it is impactful what we do, and it is reaching the field, and our patients do feel it. I have a 15-year-old son, and I took him in for his well visit, last week, and he filled out an SCOH screen, right? And to him, this is normal. And this would, again, was just didn't even exist, several years ago. So, the work that we do is impactful, and it does ultimately touch the patient, the beneficiary, and it does make an impact in the outcomes that we see and what we are able, the care that we are able to provide for them. Also, it's important for us on the payer side, right? To understand that sort of 360 view of the patient so that we are able to accurately risk stratify, right? Understand what level of care does this beneficiary need, right? If we don't have that data, we're not really equipped to make these levels of decisions. So again, just, very important, the work that we do in this collaborative is, again, to keep that patient-centered focus at the core of what we do.
Yeah, and I'm glad your son had his well visit. Hope it went well, and hope he doesn't have years more filling out the same clipboard. That's certainly a practical goal that your family can relate to. Charlene, you talked about sort of the challenges on top of challenges in terms of stretched healthcare resources. We heard from Tom as well about access issues in rural areas. I know you've been involved in a lot of efforts to improve the data infrastructure on the public health side, on connecting social service, even for at-risk kids, information about, helping pediatricians identify risks at home and elsewhere early that could have, if addressed, big impacts on long-term well-being for families and kids in terms of continue to make progress in education and living full lives. What do you see as some of the new opportunities to support these, frontline healthcare providers, as well as getting directly to a lot of people and families who may not have access to this level of care and aren't going to get it unless we figure out a cheaper and easier and less administratively burdensome way?
Yeah. Well, I mean, I think, one is we've got to prioritize, right? There are so many things where there are gaps in thinking about how to prioritize. And I'll point to one of the things that I'm particularly proud that we did at the CDC is that we launched a public health and healthcare integration team that was across the agency. And we also put out, our prioritization on performance, first ever roadmap for CDC. We developed it with many friends at CMS and CQA, all the quality measure friends. And it's actually it's up online still today. And it includes, I just want to point out two areas that I think are particularly poignant in this moment. The first is aligned to the measure for the STC hypertension management. One of the areas that I just want to call out here in this room, because it's so important, is you have to remember that pregnant women are not included in the standard hypertension management measures currently. And so one of the things we were doing at CDC was working with some of these quality measure friends, including at CMMI, where, again, states, individual payers really have the opportunity, health systems have the opportunity to be really leaders here. Because remember that hypertension and cardiovascular disease, #1 reason that Black women are dying during and after and around pregnancy. So I just want to make that call to action for if there's a way for the STC to really be a leader in this space with the continued disparities we see in maternal health. Okay, the other measures that are in there, not surprisingly, I'm going to talk about vaccines because, it's like an important topic right now. So of course, adult immunization status, prenatal immunization status were on this list. And I am currently involved with some national efforts. There are obviously a lot of policy changes that are potentially afoot as it relates to vaccines. And so I think another area where the FTC can really bring the collaboration in the same way that I'm working with some groups nationally that are trying to do this collaboration are to ensure 3 things. One, we need to be able to ensure that payers are still paying for vaccines. 2, that healthcare clinicians, provider systems are still ordering and offering vaccines. And then 3, that patients and people who want the vaccines can get them. And if I was going to make one more sort of urgent call, like, hey, we just got to keep moving, fall, winter respiratory season. I mean, at this point last year and the year before, we were so deep, and actually we did a lot of it with Duke-Margolis, so deep in planning for COVID and flu and RSV vaccine. And there's just a lot of uncertainty right now. And so I do think that states like North Carolina with the FTC can be the nimble actors that are going to be needed as we see what evolves if ACIP ends up meeting tomorrow.
Yeah, and I know there's been a lot of discussion nationally that where people may have questions about vaccine safety. I think there's a lot of consensus that talking to a clinician that you trust or another local public health voice that you trust helps with that. Those voices are stretched. The data systems of helping to identify who is at risk and how a particular provider might more easily connect with them about these issues seems like a important area. Tom, I'm gonna give you the last word in this session. You gave some nudges to this group about ways that could help with the state health plans priorities for their employees, retirees, and families. Can you nudge this group a bit more based on today's discussion?
Want to cover a couple of things. One, I think your prioritization point is spot on. And 2, we're going to continue to pay for vaccines at 100%. I think that is just the right thing to do. So give me the look there. I just want to be clear. That is the right thing to do. Yeah. I'm with you. We are fully aligned. I think, help us figure out where to start. We can make good the enemy of the perfect, but we got to start. And where we can work with DHHS to figure out where can we impact the health of the most North Carolinians, I think we got to start. And that means there's winners and losers. and that's okay. We can't, if we worry about solving every problem at once, we're gonna solve exactly 0 problems. So is there, I'm gonna go back to Yancey County. If we have the most diabetics there that are poorly managed, how can we help them get better? Why are they poorly managed? I think it's a data question too. What can we do to help them to get better managed? I think between our two groups, there's something like 4.1 million North Carolinians. We have scale, so we can solve big problems. We just gotta help us figure out where to start. I can't speak for you, but I'm okay. Like, we're not gonna get all of them the first time, the first go through. But if we start, solve a couple problems and build momentum and have a good reason for why we started, right? Like, I think the most complicated, the county with the most underrepresented people from a provider perspective that have the most unmanaged diabetes is a reasonably logical place to start. Is it perfect? Probably not, but I think that's okay. So, help us think through a roadmap of starting. And just know that we're not afraid to, we're not gonna solve every problem all at once, but we gotta make some forward momentum. And I think that will help the SDC get more funding and get more support and get more resources. Like, how can you help us log small wins on big problems? I think is the next best step forward.
Small but meaningful wins on big problems, and we've talked about a number of them here. It looks like you wanted to add something? Or?
No, I'd certainly agree.
Good.
I think you go through the Pareto, right? What is sort of the biggest bang for the buck. So, I agree. It's just sort of hot spotting those areas that we can hone in on and focus, because again, watering 1,000 flowers, doesn't really get us much, where we would like to go. And I think that's also something in this collaborative that I have recognized for the most part, that we are all aligned for the most part, across our priorities, and also understand the importance of focusing on, sort of a few that we can have some meaningful impact.
Yeah, and one of the things I say I work on the privilege of working on a lot of national health policy issues too. One of the nice things about being here is that you can't get anything done unless you work across a wide range of perspectives, Democrats, Republicans, urban populations, rural populations. So I think we have a foundation for progress. You all have done a great job of highlighting at a time when there are differences in views on many healthcare issues, funding, things like that, that it is possible to move forward. So thank you all for a great discussion and some great guidance for the next steps for the State Transformation Collaborative here. Thank you all very much. Now, I'm gonna, they deserve. Will, you've got to step off. We're now going to switch back into question comment mode. If you all have any in the room, let me know. We have a couple on the chat, and Rebecca, I'm going to call in audible here and ask you to come up and sit with us, since I think you're the best person to answer the first one I see here, which is if there are people or organizations that want to get more involved in the State Transformation Collaborative, what do they do? I know we have a online summary of the proposal and some information about Duke-Margolis, but let's just make it really practical.
Sure. Yeah, happy to take that. So a few ways that folks can get involved if they want to learn more about what's happening. We have, as Mark mentioned, a website where you can sign up to receive. We do quarterly newsletters to kind of provide updates on the conversations that we're having across our both kind of strategic and technical, as well as kind of highlighting other policy topics coming up at the federal level and the state level that are synergistic to kind of the discussions in the STC. As I mentioned, we do have our strategic and technical work groups, and we're happy to connect with folks who may be wanting to have a seat at the table and kind of contribute to the conversations at that level as well. And then we're always open, certainly to having conversations with folks and getting their vantage point kind of offline. So I think a number of different ways, ranging from the passive to the very active engagement. So welcome folks to reach out to us on that.
We've got time for one or two more questions. I'll go to one more online, which is kind of following up on, we had a lot of discussion about public health, population health, and some leading opportunities to address it, particularly following up on issues related to maternal health. Any additional comments that you all would like to make about that. Charlene, you covered the importance of not just prenatal care, but postnatal risks and having connections to good primary care around that, how important that is. Janelle, others?
Sure. Yeah, but maternal morbidity and mortality is certainly one of our priorities, public health priorities. And again, just the collaborative efforts that we take to address this is something that's very important. And again, it is one of those sort of, we've had set the term momentum, right? How do we keep the momentum going? So we know that there's much work to be done, and it is important for us to keep that in mind regardless of the headwinds that we're facing, right? If we use this collaboration, and Charlene mentioned this, understanding that public health aspect that we can add to this, and how can we be creative and make sure that if we lose funding or if we don't have the staff or whatever, right? Insert the issue here, right? How can we work collaboratively to continue moving that momentum forward? And again, choosing something that we can wrap our arms around and make sure that we're having meaningful impact and solving that, not trying to boil the ocean, but just really sort of finding what are our critical issues, how can we creatively collaborate, with our stakeholders. I think that's really the important area, and regardless of sort of what we're shifting, we sort of stay clear to these are our priorities, and we head in that direction.
I think I agree with what you said too. I think one challenge we specifically have, so I have about 200,000 teachers on the state health plan, who are, disproportionately female and of childbearing age. The state does a really bad job of giving them flexibility to take time off when they're pregnant to go see their OB. And we got to change that. You talked about razor thin margins that doctors have. What we need to be responsible for manufacturing access. So people who are pregnant, kind of go back to access and can go see their doctor when it is convenient and works for them. I think there's about 70, 80,000 employees in the state that make less than $50,000 a year that are hourly. They can't take off 3 hours in the middle of the day when their doctor can get them in. That's not a reasonable expectation. So how do we, people can't take care of themselves if they can't go see their doctor and get it. So how do we manufacture that access? And I think one of our responsibilities, something we're trying to do, is how do we pay different practices to be open at 5 or 6 in the morning when the weirdos like me are up, or open till 7 or 8 at night when people are off work so they don't have to take leave because they can't, right? Like if you're a teacher, your leave is sub-generous when we're in when school's in, and you're somewhere till 3:30 and you can't leave for 2 hours. So how do we make sure there's access until 7 o'clock, 8 o'clock at night? Because otherwise, if they don't have access, I don't think folks can manage all these things. I think it's too complicated, and I think we've set them up to fail.
Our role in this, as you mentioned, access, our role and something for us, as collaborative to challenge ourselves and challenge is to look at, are there restrictions that are in place that we may not need, right? Or are we setting up barriers? So that's another important space that we can play. I think very important as the stakeholders in this collaborative is looking at our clinical coverage policies, or again, how again can we work with stakeholders and partners to remove some of those barriers by, supporting the workforce, updating our policies, and understanding, where some of our public health colleagues that can lean in from their vantage point as well.
Can I add one last thing there, Mark? Because again, when you think about prioritizing, when you look at the data, we've actually made some progress, so much more in the intrapartum period, but the postpartum period, we've really made not much of a dent in maternal mortality. And with expanded Medicaid expansion here and in so many other states, it's just like, again, finding these opportunities to make forward progress.
No, I appreciate that point. And to try to squeeze in one more question quickly, which is important, is the state transformation collaborative focused primarily on Medicaid? Well, it certainly is focused on Medicaid in terms of having the best data and supports for providers who are stretched and patients who are have lots going on in their lives to make the most out of the Medicaid funding available in the state, and to learn more along the way about how to do better in areas like addressing the non-medical needs where the evidence is quite good already, building on it. But I think we've just been talking about is certainly, these are certainly not Medicaid only issues. They apply to teachers and people in the state plan. They apply to private insured individuals who have coverage, other coverage through their jobs. It applies in Medicare. Rebecca, you want to add any final comment on that?
No, I think the idea, to your point, Mark, it is very much across payer and across what we call lines of business. So payer organizations and Medicare, Medicaid, commercial, and then trying out what works. Like if, how do we try things and go for it? Maybe those are concentrated pilots and testing things out, but I think the intent here is to be very much multi-stakeholder, multi-payer.
We are all in this together in terms of finding more affordable ways to keep people healthy and get them more engaged in their care. Thank you all very much again for a great discussion. Thanks. Rebecca, we can go back and sit down too. Okay. I would like to now turn to our final panel for the day. We're going to continue looking ahead with a bit of a deeper dive on federal perspectives on how to advance prevention, empower people, help support better choices and competition to make healthcare more effective. And very pleased for this segment to be joined by our two final speakers and guests from CMS and the Washington D.C. area. So I'd like to introduce Dr. They're getting mic'd up now, which is why I'm sitting on this stage by myself. But I'm going to go ahead and do that. Dr. Susanna Bernheim is the Chief Medical Officer of the Center for Medicare and Medicaid Innovation. Dr. Bernheim has been a public servant for some time now. It's sort of like the dog years, so at least 10 or 15. And she leads the center's newly announced strategic pillar focusing on evidence-based prevention, something that was called out in the last panel as an area where there is a lot of interest in using evidence, developing more evidence, and making a difference in risk factors and chronic disease. She also oversees the quality measurement strategy for the center's payment models and provides and helps expand the clinical and expert input into the public and private into the design and improvement in those models. Kate Davidson, speaking of dog years in the federal government, it's been more, is the director of the Learning and Diffusion Group at the Center for Medicare and Medicaid Innovation. Kate's portfolio includes accelerating healthcare system transformation by leveraging, on the one hand, what we know in the science, the evidence on care improvement and access improvement through the center's models and potential model. But she also leads the multi-payer alignment strategy for the CMMI efforts, including using the Healthcare Payment Learning and Action Network area where I and our colleagues at Duke-Margolis have the privilege of providing some important technical support in a very important public-private collaboration. So thank you all for being here. Susanna, maybe I'll start with you. You heard about the strategic refresh. Will highlighted it in the last session. There are three pillars, but there's one that you're particularly focused on. Can you say a little bit more about it and help build on the discussion we've already had and how the work that you're doing can synergize with the collaborative efforts here in North Carolina?
Yeah, sure. Hi, it's nice to be here. Nice to see you all. When our new director, Abe Sutton, came in January, we met and looked at the experiences of the center before, the statutory authorities we have to test new payment models, the priorities of the new administration, and set forth this new strategy that came out last month. As Will mentioned, it has three pillars. The first is promoting evidence-based prevention, and I'll talk a little bit more about that, but just to say the other two, it is driving choice and competition and empowering patients to reach their health goals. Usually do it in the other order. Empowering comes to driving choice and competition with a foundational principle around protecting taxpayer dollars. So I think I'll just say like a couple of words about what we're trying to do in each of those and then talk about how it connects to the state efforts. So when we talk about promoting evidence-based prevention, the first thing I just want to say is we think expansively about prevention. After we put out our strategy paper, a number of people we spoke to said, shouldn't we also be focusing on chronic disease management? So just to say it clearly, we are focused on what is traditional primary and secondary prevention, screening for, preventing diseases, but very focused also on what is called tertiary prevention, really the importance of addressing the chronic disease, which is prevalent in the populations we serve, and managing and trying to slow the progression of those diseases. And we're really we've done a lot in the center in prevention before through our primary care models, through the Million Hearts model, through the Medicare Diabetes Prevention Project. But we see an opportunity to really strengthen our approach to prevention by emphasizing opportunities for payment reform to drive better nutrition and lifestyle changes and physical activity. And so that's the focus of our prevention pillar right now. Again, we can talk more about sort of how we're going to do that, but that's where we're putting our energy for that pillar. When it comes to the second pillar, Kate can talk more about it, but the fundamental concept is that if we give people usable data, they can better understand their health status, interact with their providers, make good choices about their health, and they may be able to we're also thinking about patient-facing apps that create transparency around the choices they have of what providers they go to. So both of those concepts are embedded in that second pillar. And then the third around choice and competition encompasses a lot of different things. We are thinking about how to level the playing field somewhat between original Medicare, Medicare Advantage, Medicaid, what the flexibilities and incentives are in those programs. We are thinking about how to engage independent and rural providers in value-based payment programs. And we are thinking about how to make it easier as a part of that to engage in our programs in decreasing the administrative burden. And then again, the underlying piece is protecting the taxpayer, really leaning into the statutory mandate of the center that we can expand models if they're shown to be either cost neutral or cost savings and maintain quality, looking to make sure that more of our models reach those cost saving goals, embedding more downside risk, things like that into the model. So those are the highlights of the pillars. I think lots of that is relevant for the efforts here. I think, although we don't say the word value-based care in the same way, it underlies everything we're doing, right? The center is based on the idea of moving away from a fee-for-service system to driving better outcomes at lower cost. So everything we're doing is trying to find creative ways to use alternative payment models to do that. It totally aligns with what we're trying to do in the state. And I think that in the prevention and the patient empowerment pillar, we're really thinking about many of the same things you are around whole person health. Again, slightly new terminology, but fundamentally, what are the barriers to people being healthier? What are their personal barriers? What are their community barriers? What are the upstream drivers that impact their ability to be as healthy as possible? So I think you'll see in the models that come out new approaches, but a lot of the same aligned goals as what the state's trying to do.
Great. Thanks for that overview and going a bit deeper. I'm going to come back to some of those, but first turning to Kate. So your pretty complicated job includes connecting all of these priorities out to the broader community, including organizations serving Medicare beneficiaries and the health plans, but also those working on employer coverage and kind of the whole set of perspectives that we've had together in this meeting. We just heard from Susanna about how the fundamental focus on moving to value-based care hasn't changed. Maybe I'd say an even bigger emphasis though on how do we make this less burdensome administrative? How do we make it simpler? And we've talked a lot already about how data interoperability and getting to more consistent, not standard approaches for doing value-based care from the provider, the patient perspective, or the prior auth or performance measurement, things that matter in value-based care have just been a lot more administratively burdensome than, following the CMS standard code set for fee for service. But there are some differences this time around. Our state transformation collaborative here was actually born out of a CMMI pilot previously with 3 other states around advancing public-private collaboration. That was always intended as kind of a temporary launch support with the idea of transitioning to a more sustainable model. With the new administration, that's happened. It's good to see that our work is continuing, but even though the specific programs have changed, there's been a lot of sunsetting of some previous initiatives and some new ones started. Could you talk a little bit more about where we're headed, what's how you're building on some of the previous work and what it means for the state transformation collaborative here in particular?
Yeah, absolutely. Number one, it's so nice to be back here and see so many familiar faces, because just what Mark described, being able to come and hear directly from you all who are thinking about the state of North Carolina, but also hearing very local issues, I think is just really feeds the larger strategy that we have at CMMI and CMS. And so thank you for having me back. Yeah, so, I've been really fortunate to be able to partner under Mark's leadership for the Healthcare Payment Learning and Action Network, or the LAN. And that is a CMMI funded, but it's also the largest private-public partnership that we have at CMS. And so it makes sense that partnership really is aligned with the strategy that we have and we're trying to execute against at CMMI and at the larger strategy at CMS as well. And so as we were rethinking as we were developing this new strategy and the pillars, and ultimately the principle of saving the federal taxpayer dollars, which lies underneath all of the pillars that support the strategy at CMMI, we were thinking about what are the things that are really essential for us to learn from our private partners, and how do we start to feed new and innovative ideas and make sure that we're incorporating that in our own strategy as well. And so it's no surprise that the LAN is launching 4 new initiatives. 3 of those initiatives are aligned with the pillars of that CMMI has outlined. So that includes prevention, evidence-based prevention. That includes driving market competition. It also includes patient empowerment. But in the most recent months, we've really been focusing a lot on how we can leverage technology and really drive a technology-enabled ecosystem across the country. And so those conversations, that dialogue is well underway. We've invited a big tent new stakeholders, which is also really exciting, folks that we haven't engaged in the LAN with before. And you'll see as part of everything that we do with the LAN that technology is going to be a part of every single one of the initiatives that we're taking, that we're driving toward. And I think that ties back to the STC work around administrative burden, around finding efficiencies as well.
Yeah, and as part of that process, it's been, again, really privileged to be a part of it. And, I know the LAN now is operating on a tight budget, but very much intends to broaden the tent there as well, with some new perspectives, including technology companies that are really good in general at engaging with people, but maybe haven't had as much opportunities or haven't figured out how to overcome the barriers and the connections to providers and patients directly and so forth that might be helpful. Providers who are involved in telehealth or technology-enabled care or functional health approaches to reach people more easily. But Susanna, coming back to your point, it is a key principle in this new strategy of emphasizing prevention, primary, secondary, tertiary, but evidence-based is also a key part of that phrase. There have been a number of CMMI efforts in this space in the past. One that's come up in a lot of these recent LAN discussions is looking at the diabetes prevention program, for example, which was a CMMI previous pilot that showed success on the sort of the taxpayer standpoint and the outcome standpoint, is available, but hasn't really scaled and hasn't really fully entered the technology era. You don't have to talk about just that one, but we have a lot of interest here. I know our providers do, in not wasting time plans and patients, not reducing time and burden, but actually working, getting access to programs that really work? How can we help with advancing this evidence-based goal?
Yeah, so we're talking about a lot about MDPP ourselves. Because exactly what you said, it worked, and yet we didn't get a ton of uptake. And so I think the way I'm thinking about the sort of evidence-based prevention concept is there's actually a fair amount of quote unquote interventions, things that we could change in our lives that have very strong evidence for helping our healthcare. What we don't have the great evidence about is how do we deliver that at the healthcare system? How do we change the incentives and the payment and the flexibility to successfully, make MDPP more available, or change the way our clinics function to, have shared medical appointments, or, use some of the data from what has been studied in food as medicine, right? There's a lot of pieces of evidence, but I think what we really want to try to do is figure out in all of our models, what are the different ways that we can embed flexibilities, payment changes, provider incentives, direct incentives for beneficiaries, connections to community providers. There's a lot of levers we have. And so the goal of our group now, when I say our group, I mean the little group of folks thinking about this prevention pillar, is to think about how can prevention, particularly focused on places where we have good evidence about lifestyle changes, but we don't know necessarily how best to deliver them, embed that in different facets of models, depending on the model, right? So it has to look different if the model is focused on nephrology practices versus a state or an ACO. But we're really thinking about a range of different things. And to just echo something that Kate said, where does technology fit in? Where can technology help folks access, asynchronous support? How can we use technology to help beneficiaries with, nudges towards different things? And where do we bring more support for providers to connect with evidence-based practices that are in the community? So there's a lot of different channels that we're considering, but we're moving fast to bring some new models forward. And I hope that you'll see in the vast majority of them a really strong presence of tests of new ways of bringing some of these pieces forward.
And Kate, as you know, you're in the State Transformation Collaborative, focusing on the underlying data that's needed for that, alignment on measures and shared learnings about what is working. Any further guidance for us on places where you'd like to nudge this further work? We've talked about the emphasis on empowering individual consumers, getting usable, timely data into their hands. We talked about reducing burdens on providers through alignment and better data sharing, ways that we can help.
Yeah, I mean, my team has really been responsible over the years also so we talked about big picture multi-payer alignment, but also ensuring that our models have a patient-centered approach across the entire portfolio. So think big picture down to granular. And I think that as we've been doing this reset on our strategy, one of the things that I've been doing a lot of thinking about is trying to come at this work with fresh eyes and thinking about what patients and how they experience the healthcare system through their own lens. And I'm going to tell a tiny bit of a story, if that's okay. Someone who's very close to me recently was diagnosed with advanced cancer. And in that whole process, she's been talking to me a lot about what her experience has been. And, first she was misdiagnosed several times. This is someone who has young children, a woman with young children. And so this is a very important early diagnosis, and treatment is very important for her. So she was misdiagnosed. And then she was referred, and they couldn't find someone to do the initial surgery. They finally located a surgeon, and the surgeon did the wrong surgery. And then when they made the referral for her to begin treatment after they had finally done all the diagnostics and made the referral for treatment, when she arrived at the treatment facility, she hadn't gotten prior authorization, and she didn't know. And so then she calls me and she said, "What do I do? I'm exhausted." And now all of a sudden treatment, which is already exhausting and scary and all these things, becomes insurmountable, and you don't trust your care team. And what's the great equalizer that she was missing in all of that? All of that her providers had information, her payers had information, right? But she didn't have information about her own healthcare. She couldn't have gone in and advocated with that surgeon and said, no, that's the wrong procedure, or that's not what I'm supposed to be here to receive treatment. Or she showed up and she didn't have the information about whether she had the prior authorization or not. And so I think about those stories that people tell me all the time, or that I hear about, and I think about what is it that we could do that's new. You say, what could we do here? Let's really talk about what it would take to equalize patients, giving them information and having them part of their own care team, having them be able to have conversations. And that does mean alignment and quality measures, but it means thinking about quality measures that matter most to patients, and then being able to use that, leverage that information for wellness plans and for treatment plans.
And Suzanne, I'm gonna ask you about picking up on that really compelling story, and I totally agree. We need more of those motivating our work, and it seems like a great way to connect in more people around the state. Your other hat is performance measurement. So an area where we've been focused here on a lot of interest in reducing the burden, recognizing that is a key part of value-based care. Effective measures, what really matter to patients. We've got a main focus on primary care, but we've talked about specialty care as well. The data are kind of there, but they're not systematic. The prior auth proposal that CMS is moving forward on this week, I think there may even be more to come on that. Sounds like it's going to help address it by, really creating a win-win of like faster ways of getting critical data and being clear about what that is in advance, and faster expectations of decisions and payment, and maybe sharing it with the patients in a much more actionable way as well. Is that driving your work on the performance measurement side?
Yeah, I feel like we're almost doing two things that sound contradictory but aren't, right? On the one hand, we're really still working at CMS to kind of align and reduce the number of measures, right? I think it took some time, but we've actually had some good impact of the work called the Universal Foundation that really first came out a couple of years ago, where we said, here's a core set of primary care measures. And then it takes, rulemaking and engagement and whatever, but now almost all of the CMS programs have centered on that set of measures. And turns out, I think North Carolina is thinking about some very similar measures, right? So they're
Certainly been watching closely.
yeah, and payers and I believe the LAN weighed in to help us decide on that set. So it's been bi-directional, but it's slow. But there is progress towards sort of this decreased burden. And if we're going to talk about diabetes, even if there's trade-offs and one isn't perfect, let's all align around the same measure, right? So we've definitely made some progress there. But I also think part of what you're saying is soon, I don't know what soon means exactly, we're actually on the verge of having a lot more ease of getting data. And that's going to allow us, I think, to lighten up a little bit on the measure counting, because there won't be so much burden involved with each individual measure. So we sort of have to do both things. And the center, I'll say a couple of things that we're thinking about that sort of are in both of those buckets. We've had a strategy called the quality pathway for the models, where we try to say, let's really focus the quality measures on the particular primary goals of this model, hopefully using universal foundation measures, but not if we're trying to drive a particular aspect of quality. And let's make sure that our evaluation focuses on that same aspect of quality. Let's upfront say, what are we trying to do here? And let's make sure all the pieces line up. Now that prevention's become such a focus, we're taking a look at that same concept and thinking, are there some core measures that are going to help us understand if all these tests we're doing are actually getting to better outcomes for beneficiaries focused on prevention? And there's a whole other conversation to have about how some of those outcomes take a long time to see. So what are the intermediate markers? But we're also thinking about how we can bring more data in, right? So not on the quality measurement per se, but again, relevant to what's happened in this state. Why, when we're asking people about transportation and food insecurity, maybe we want to also ask them about how much physical activity they're getting, right? Can we add some screening around some of these fundamental things we're trying to drive, so that doctors and patients are in conversation, just like we did with some of the HRSNs, around some of the changes in lifestyle we're trying to drive? And how can we do a better job of collecting what's happening in the clinic? So we often give flexibilities, and this is really Kate's work. I'm now totally speaking for Kate because she's been leading this, but how can we in a more standardized fashion understand what providers are doing in our models with that flexibility so we know it works? So there's both decreasing the measures, focusing the measures, but there's also trying to bring more data in so we can understand what's working.
Let's bring more data in. A lot of people, looked at interoperability rules. I know we're almost out of time, but it seems like a really important point where things may be different. And just we haven't gotten the standards are there, but the data doesn't seem to come quickly and freely and easily that people really want or that a provider really needs. Some of that's claims information, as we've talked about. A lot of it's not. But it does seem like we're at a kind of a shift point where in our alignment work to date, we've really focused on how do we get to the same measures and how do we get kind of existing data and maybe a little bit more to flow. It does seem like we're at a point where that could be ramped up and where this administration, this is my editorializing, you have to agree with it, is ready to make some deals around, on the one hand, if providers can get that information out of their electronic record systems, or we can find ways to capture data directly from patients, and that gets to the payers, gets to CMS. CMS is willing to provide data back, pay faster, things that really create win-wins, and the technology's kind of there. So just final thoughts for our state transformation collaborative. This has to be very quick because we're almost out of time. What else should we be focusing on, and how else can we really advance what seems like could be a phase shift in bringing down costs of getting to and implementing value-based care and empowering patients along the way?
Kate, do you want to take that?
Sure. Give me the hot potato. So I think that we roughly know what payment enables, right? We roughly know what we're headed towards in terms of value-based care, APM adoption. I think we have some broad sketches around what we're trying to incentivize, and I think we've got this directional alignment. I think that somebody said it earlier around where do we dig deeper, where do we find much more alignment on very specific design features. I think interoperability is one of them. And so I think that continues to be a conversation. But then I also think there's these things that are incremental, but that are really powerful. And can promote and change the way that people are experiencing healthcare and ultimately health outcomes in really important ways, and that can be scaled and that don't require a ton of time to study and don't require a ton of time to be able to test in order for us to bring it to scale in a community, across a state, and nationally. And so I think we should be really honing in on some of those things as well, as a healthcare system that's learning and growing over time.
So not just aligning on the measures, we got ways to get there, not just aligning on the data sharing, but now the next step, aligning on the rapid learning about what's really working. Thank you all very much for coming down. We're always happy to for you to visit North Carolina and get out of DC, which it was.
So are we.
It's not any cool. It's 102 degrees here. Thank you all for being here.
Thank you.
Thank you.
All of you, both here in the room and with us virtually, for being here as well. This is obviously a work in progress. It is a work where we are seeing not the full bridge being built. You're seeing the frame. You're seeing people's needs being addressed more effectively by moving across it, and you see hopefully a good path for the future. This is only going to work with continued collaboration, people willing to find that common ground despite differences in political views, despite differences in perspectives, and reminding, I think we've got even more opportunities to do it now, to bring in that patient and consumer perspective to drive this work forward even more effectively. It's been a great opportunity to be with you today. I want to thank everyone involved with the State Transformation Collaborative effort in advance for what's coming. That includes our federal partners in this work at CMS and other agencies. It includes our state partners, DHHS, the treasurer, the state health plan, the governor's office, and very important right now, the assembly, as they're thinking about future steps to advance more affordable and efficient patient-centered, prevention-oriented care in North Carolina. It includes all of you who joined us today, and it includes very special final thanks to the Duke-Margolis team, Rebecca Whitaker and all of her colleagues who are continuing to put this together and help us move forward together. Thank you all very much and have a